At this time, I'd like to turn today's program over to Canada Health InfoWay. The floor is yours.
Thank you, Michael. Good afternoon, everyone. This is Fraser Ratchford from Canada Health InfoWay, and I'd like to welcome you to our second in the series of looking at the results and findings from the Data Impact Challenge. Today we're going to be focusing on two of the Choosing Wisely questions, and basically they're all around sort of that inappropriate prescribing in older adults. We have a great panel lined up for you, so let's get started. I think if you're on the call, then you know which dial-in number you're using, so that's good. But we're also encouraging everyone to tweet today. You've got @InfoWay and the hashtag there to include in your tweet, so please feel free to do that as we go through the webinar. Just to note, today, like most of our webinars, we are recording the call. We will be posting it on the Challenge website, and it will be used for future internal and external education sessions. As Michael started off saying, we're not going to be doing voice questions today, but we will be using the Q&A feature that is located on the top of your screen. You can see that now, so that there it is. Type in your question to all panelists, and then we will attempt to address it as we go through the webinar. If you're thinking of questions as being presented, please queue them up now so that we can try to get them all there, and that we don't have a lull in the conversation, so to speak. Let's just review what we're going to do today. So I'm going to give you a little background. My colleague Simon is going to discuss some of the summary of findings, and then we're really excited to have 3 presentations around these questions that we're concentrating on today. And then we have a facilitator to facilitate the discussion about what we've learned, how we can share it, and what further analysis may need to be done. So we're going to do all that in an hour, so hang on to your seats. So just a little bit about Canada Health InfoWay and our challenges. Our vision here at Canada Health InfoWay is healthier Canadians through the use of digital health. Together with our partners, we help accelerate the development, adoption, and effective use of digital health solutions across the country. Our Imagination series of challenges was designed to sort of inspire, provoke, and promote innovation in health and healthcare, and foster a community of innovators in Canada. And certainly with this particular challenge, the Data Impact Challenge, we feel that we've fostered a community of researchers and analysts who were able to answer some of these important questions. Each of our challenges is different, but they all do share the ultimate goal to improve the quality of care and the patient experience. We couldn't do this without our supporting organizations, and they're up here listed. All of them in their part either help formulate questions, communicate to their stakeholders and to their community itself. A special thanks to Choosing Wisely Canada, the Canadian Institute for Health Information, and the Canadian Association for Health Services and Policy Research, as they really helped us on this particular challenge refine and define the 13 or 14 questions that were asked in this challenge. To specifically hone in on the impact of this challenge and its purpose, well, it was to source relevant information to a set of questions on topics about quality and appropriateness of care identified by policymakers. And it really tested the feasibility of, is there another mechanism we can use to answer these questions? Often these questions have gone unaddressed, or people just think it might be too difficult to answer them. But I think all of our challenge participants have proved that that's not the case. And when we put it out there, if we build it, the answers will come. And so all of the challenge submissions and answers can be found on our challenge website. So if you haven't already done so, please feel free to look at the answers that have been provided by our challenge participants. I'm going to now turn it over to Simon Higgins, our Director of Benefits Realization here at Canada Health InfoWay, and he's going to walk you through a bit of the results.
Thanks very much, Fraser. So Fraser described a bit about the process. When we put these questions out there, we really didn't know what to expect, and I think the results were really exciting and pleasing for all of us. So 6 questions, one of which was a multiple-part question with some of those Choosing Wisely Canada recommendations. We gave teams 64 days over the course of the summer to prepare answers. And in a total, we got 41 submissions, so a great number of submissions and a good diversity across those questions. As Fraser said, all of those submissions are available on the website and really an excellent repository of findings around various parts of the healthcare system. The last piece of the puzzle in the result is the judges. So 35 judges. Each of those submissions was judged at least 5 times by judges that came from different backgrounds, from analysis backgrounds or policy backgrounds, and all of those judges are listed on the website as well. So a really great group there, and gives a good, rich sense of which is some of the top analysis we received. So I'm going to move now to talk a little bit about the specific questions we're tackling today. And these questions originate from Choosing Wisely Canada, and they're both from their geriatrics recommendations. So we were asking questions related to recommendation number 2, which was don't use benzodiazepines or other sedative hypnotics in older adults as a first choice for insomnia, agitation, or delirium. And I've also included the full text for that recommendation, but that was the first recommendation we were looking at. And the second recommendation that we were looking at was recommendation number 4, which is don't use antipsychotics as a first choice to treat behavioral and psychological symptoms of dementia. So 2 very important questions for geriatrics, and we wanted to support Choosing Wisely Canada in understanding the baseline and the current state across country from multiple data sources. So we generated 2 questions based upon these, and the next slide shows what those 2 questions are. So these are the 2 questions that you saw within the challenge, and these are the questions that our teams have attempted to answer. So on the next slide, what we've got is a very high-level summary of findings. And I would say that one of the things we found most interesting about the submissions is that we got data that looked at different sectors, looked at different perspectives on the question, different data sets, different time frames, different populations. So we get answers that have different ranges. And so in this particular one, you'll note there's a couple that come from primary care that have very different kinds of ranges than that which comes from the more home care, complex continuing care, long-term care. So some variation in there, and that's why the sort of richness of data in those submissions is so important. On the second set of submissions relating to the second question, a bit more of some ranges, especially when we start focusing in on those long-term care settings or inpatient settings of various kinds. We see a bit more of a range appearing. So this is our summary of the findings, but absolutely in this case what we found is that the findings are very hard to summarize because they come from different perspectives, and hence our interest in being able to share with you some of the details from some of those specific presentations. So without further ado, we're going to launch into that. I'd like to introduce our first team. They're the interrators of the lost data. And what I'll be doing is turning it over to this team. They'll spend a few minutes presenting their findings, and then we're going to encourage all of you on the line to submit some questions, which we'll ask the team to respond to. So please have your questions ready as they're speaking, and I'll turn it over now to the interrators.
Awesome. Thank you for the introduction. Our question that we chose to answer for this data challenge was what proportion of older adults have been prescribed benzodiazepines or other sedative hypnotics for insomnia, agitation, and/or delirium? And looking at ways to answer this question, we looked at 2 different data sources. So one was the Continuing Care Reporting System. These were RAI MDS 2.0 assessments conducted in these settings for all patients who receive care in CCC and long-term care nursing home facilities. And then we also looked at long-stay home care clients using the home care reporting system. So we had a fairly large sample across many different provinces in Ontario. For long-term care nursing home, we had about 800,000 individuals from 8 provinces. In complex continuing care, we had 83,000 individuals from 2 provinces. And in home care, we had just over 1 million assessments from 5 different provinces. Inclusion criteria, just as the question says, were those who were aged 65 years old and older. And in long-term care and CCC, we looked at those with insomnia, agitation, or delirium. Unfortunately, the home care assessment doesn't have any items on insomnia in it, so we could only look at those with agitation or delirium.
So presenting the first results, this graph shows that the proportion of persons with insomnia, agitation, or delirium receiving anxiolytics or hypnotics decreased over time in long-term care and CCC from 2009 to 2014, whereas the proportion of persons with agitation or delirium in long-stay home care receiving the same drugs increased for the same period of time. The decline in the proportion of persons with insomnia or delirium receiving anxiolytics or hypnotics over time in LTC and CCC could be a result of the increasing awareness on the diverse drug reactions and negative effects of excessive sedation in the elderly, such as cognitive impairment and increasing risk for falls, and for the increase in the proportion of persons with agitation or delirium in long-stay home care receiving these drugs from 2009 to 2014, this may reflect an increase in the health complexity of this population over time.
Next slide, please. So here, these are some of the additional analysis that we have done. So it's related to the previous one. So here, we are basically interested in looking at how does aggression or depression affects the use of anxiolytics or hypnotic medications within the individuals with insomnia, agitation, and delirium. And basically what we found, so if you look at the top of the graph, the top graph basically looks at across different settings. If you have aggression, then you're likely to have more anxiolytics or hypnotics prescribed. And if you look at the bottom graph, we see basically the same trend. So if you have a depression, you're more likely to get the hypnotics and then other medications.
So just a few concluding remarks. The proportion of persons with insomnia, agitation, or delirium who received anxiolytics or hypnotics decreased over time in long-term care and complex continuing care settings, but it increased over time amongst long-stay home care clients. Persons who show symptoms of possible depression and aggressive behavior were more likely to receive anxiolytics or hypnotics across all three care settings that we looked at. And a couple limitations to note: only the general type and not the name of the medication be determined from this assessment, and reasons for prescribing could not be determined. Therefore, one cannot conclude the appropriateness of these prescribing patterns. Thank you.
That's great. Thank you so much. Really interesting findings. So I encourage folks now that are participating in the webinar to send in your questions through that Q&A box. We do have one here already. So there was some hypotheses you put forward about what's causing the decline in those long-term care and complex continuing care scenarios. Any thoughts on how you might go about confirming that hypothesis?
I don't know. I think we should look at historical. Also, the other thing that I was discussing with my group is that some changes in the nursing home regulations, so also could have some impact in the way that drugs have been prescribed in long-term care. So I think we should dig in the literature and look if there were changes that were made in the regulations for those settings, and also take a better look in the characteristics of the clients of the home care settings to see how they changed over time, to see if they became more complex during this period.
Great, great, very interesting. I think that makes a lot of sense. Another question we have, we've got a comment coming in that the public reporting of antipsychotic use is what's driving change. And I wonder if somebody would like to make a comment on that one.
Yeah, I mean, that certainly could be the reason. It'd be interesting to look at the perceptions of their use amongst the providers and to see if that is actually what is driving the change in their just general awareness of the perhaps the inappropriate provision of these medications, if that really is being heard by the providers. Great, thanks.
And one last question. This kind of analysis and on this specific topic, is this net new analysis for you and your group, or is this kind of analysis that you've done in the past around these specific medications?
We at Interact Canada do this type of analysis very frequently. This specific question was something that was new to us, especially looking at the appropriateness of prescribing these medications and looking at that subgroup with insomnia, agitation, or delirium. And this is definitely work that we intend to kind of take a little bit further and pursue, definitely pursue very hard, so that, I think this is important information that should be disseminated.
Excellent. That's great. Thanks so much, the Interators of Lost Data. Really appreciate your presentation.
Thank you.
Thank you.
So we're going to move along now and have our team from Interact Canada, and I'd like to ask Chris Perlman to come on the line and go ahead and start your presentation.
Great. Thanks very much, and thanks for putting forth this great initiative. So we took a variety of databases similarly, to the last presentation, to try and gather as much as we could about a pan-Canadian perspective on antipsychotic use among older adults with dementia. We utilized data from the Interact suite of assessment instruments, and much of this data is available from the Canadian Institute for Health Information, to look at antipsychotic use in home care. So we had data from 5 provinces, about 43,000 people. We also had data on individuals in acute hospitals who are on alternate level of care. Those individuals were also assessed with the home care instrument, and that was about 7,500 cases as well as complex continuing care hospitals from 2 provinces, but the majority of these data were actually from Ontario. And then our largest data holding was from long-term care nursing homes from 8 provinces and 1 territory. Now, the reason why these samples look a lot different than the ones previously presented was that we took a sort of a point prevalence approach to this and said, for each year of data that we have, or the most recent year of data that we have available for each of these holdings, we took the person's assessment that was closest to June 1st as an arbitrary sort of point in time, and just looked at those individuals. So we're basically looking at data from 2014. There were some from a little bit earlier, 2013 as well. Can we just go back to the last slide for 1 second? So in our analyses, we also stratified by the prevalence or the presence, of behaviors and psychological symptoms. And so we utilized other kinds of information from the NRI tools, such as aggressive behavior scale, presence of hallucinations and delusions. We also did some sensitivity analyses looking at people with delirium in addition to these symptoms, but we didn't report those analyses. It didn't make a huge difference in complex continuing care, but some of the rates did move by about 1 or 2%. Okay, on the last slide. So here are our summarized results, and we stratified them again amongst individuals with no symptoms of aggression or psychosis, so that's the red line. The violet line being those with aggressive behavior, the yellow being those with psychosis, or both. And so we see the mean scores tend to be highest in sort of more institutionalized types of settings, with the highest rates amongst individuals who are displaying both aggressive behavior as well as psychosis. But I think with this, one of the most alarming things that we sort of came across provinces was the red bar in individuals with no aggression and no psychosis. So while antipsychotic medication may be inappropriate in general for any of these individuals, you could perhaps make the assumption that it's perhaps most inappropriate for individuals not experiencing any of these kinds of behavioral or psychological symptoms. Another interesting finding here is the range in scores. So that's the error bars. Those are the range in scores between provinces that we came across. So, of course, in complex continuing care, there was a little bit less range, but for individuals receiving both treatments, or both, individuals experiencing both symptoms, there was quite a bit of range between provinces. And so I think this, can't be necessarily conclusive that it's inappropriate prescribing because we don't know everything about the situation. However, we do know, about their symptom and behavioral profiles. The other thing here is that we don't know the dose or the precursors to the prescription of the antipsychotic medication. So there are some limitations that do require further inquiry. So thank you very much.
That's great. Thanks so much, Chris. Really appreciate that. And again, encouraging folks to now start entering in some of their questions into the Q&A tool. The first one we have here relates to that red bar, the no symptom bar, and curious about what kind of techniques or analysis might be required to get a better understanding of the reason for prescribing in those cases.
Yeah, I mean, it's very difficult with, obviously with secondary data to get at very specific reasoning around some of these cases other than, doing a case study within a specific setting. However, I guess with the advantage to these sort of large clinical data holdings is that we can start to look at and identify at least the sort of the clinical profile of individuals receiving or have been prescribed antipsychotic medications who don't have any of the symptoms we've looked at to say, well, who are these patients? What is their profile? And that could perhaps drive further inquiry into whether or not there's some sort of underlying common practice existing across these settings to prescribing antipsychotics amongst individuals even without, the behavioral or psychological symptoms.
Great, thanks. Very interesting. And then one last quick question is more of a process question we've got, which is about how long did it take you to conduct this analysis, and what were some of the steps that were most time-consuming?
The analyses actually didn't take very long at all. We're fortunate, INRI Canada has a data sharing agreement with CIHI, so we had a lot of these data holdings on hand. The thing I guess it prompted for us that took a little bit of time and was most difficult is the sort of data linkages across provinces and ensuring that when taking, finding the most recent assessment and some of that sort of data management and activity in terms of setting up the data for analysis perhaps was the most time-consuming. But now, the encouraging thing about this opportunity is that we've done a lot of that work now. So actually doing some of these analyses, particularly when we're just looking at, the prevalence or frequency of certain events, can be quite efficient.
Great, that's exciting to hear. Excellent, thank you so much. So really appreciate your submission and your presentation, Chris.
Thank you.
So next, we're going to move along to our last team presentation, and that's from the Ontario Drug Policy Research Network team. So I'd like to introduce Diana Martins and hand it over to you.
Thanks. So hi, everyone. We submitted an answer to the question, what portion of older adults have been prescribed antipsychotics to treat behavioral and psychological symptoms of dementia? And so to answer this question, we examined antipsychotic prescription rates each year between fiscal years 2003 and 2012 among adults aged 65 and older who were active beneficiaries of the Ontario Drug Benefit Program. And so this benefit program provides drug coverage to all individuals aged 65 and older living in Ontario. And so here we define dementia patients as those who had a dementia diagnosis code or if they had a cognitive enhancer prescription using an algorithm and codes that have been used in this area of research. And so since the question wanted us to identify the use of antipsychotics for the behavioral and psychological symptoms of dementia, we excluded dementia patients who may have been prescribed an antipsychotic for other uses. And so we then calculated rates for each fiscal year overall and stratified by whether the individual lived in long-term care versus community. And what we did here was we created our numerator, which was comprised of beneficiaries aged 65 and older with dementia who were prescribed an antipsychotic. And then we calculated the rates of antipsychotic use to treat BPSD using two denominators. The first was comprised of all individuals aged 65 and older who were active beneficiaries of the drug program. And then we further limited our second denominator to those who were 65 years of age and older, who are active beneficiaries of the drug program and who also had a diagnosis of dementia. So next slide. So this slide is just presenting the results of our analysis, and I'll try and break it up as I go through it. In our primary analysis, represented by the solid lines in the figure, we looked at rates of antipsychotic use among elderly beneficiaries and found that the rates have not really changed much over time in Ontario. And as you can see, the overall rate represented in the solid black line in 2003 was about 2.5%. But we see that the rates differed by residents, with about 30% in long-term care setting represented by the solid red line versus 1.4% in the community setting represented by the solid blue line. But in our secondary analysis, which is presented by the dashed lines, which was limited to a denominator that had individuals with a diagnosis of dementia, we found that the portion of antipsychotics prescribed is much higher compared to when we used all active drug beneficiaries as the denominator. And so here, looking at the dashed lines, we saw that the overall rates represented in the black line, the dashed black line, decreased slightly over time from about 26% in 2003 to 21% in 2013. And we still found the same trend with the rates being higher in long-term care, which was about 40%, compared to those in community, which was about 16%. And that summarizes the results of our analysis.
Thanks so much, Diana. Very, very interesting, interesting findings. So again, I'll encourage participants to chime in now with your questions for Diana. The first one we have relates to obviously you were able to do some analysis of prescribing trends in the community, which was unique from the presentations we've seen today. And I wonder if just your comment about how surprising those findings were.
Yeah, so I guess there's been a concern about the prescribing in long-term care homes, but there hasn't been too much focus in the community rates of prescribing, and we really wanted to stratify our findings originally just to show what might be driving the prescribing rates. And we did find that the higher rate of prescribing in the community setting, we're not too sure what the prescribing rate, like what is driving these factors. We have been thinking more and more about it, and to add on to kind of this analysis, we wanted to look at how many of these people do end up in long-term care within a certain amount of time. So that's something that we're kind of interested in looking at in the future.
Great. Okay, excellent to hear. We have another question, which was, how was the diagnosis of dementia determined?
Right, so this was, we actually leveraged data from the Ontario Health Insurance Plan database as well as the hospital records from the discharge abstract databases here. And so what we did is we used ICD-9 and 10 codes that would have been found here that had an indication of dementia, and then as well as looking at an OHIP C codes for dementia as well. And then we also looked at prescription for cognitive enhancement.
Great. Okay, thank you very much. And one last quick question. That's about the makeup of your team. So clearly, you're a team it looks like it's a team that you've worked together before. Can you tell us a bit about your team and the mandate of your group?
Yeah, of course. And they apologize they couldn't be here. We actually had a conflicting meeting at the same time. But so we're based in Ontario, and we work closely. We have analysts and epidemiologists at the Institute for Clinical Evaluative Sciences here, which has access to the Health Administrative Database. And we currently have 2 analysts who work with the team, and one of them who led this project. And I'm an epidemiologist working with the team, and we also have a project manager and 2 of our scientists who work with the team were part of this, and a lot of our research is focused in the area of drug policy work. So we work closely with the Ministry of Health, Ontario Public Drug Programs, and when this question came up, there was already kind of research that we were doing in this area that was prompted by the Ministry of Health. So it was definitely an interesting topic to look at, and we do a lot of research in the area of drug utilization in Ontario, looking at appropriate use and just informing government decisions around this.
Great. Thank you very much. Really interesting. And we've got one last question, and that was, where do you get the prescription data when looking at dementia versus benzo prescriptions?
Sorry, what do you mean?
Well, that's an excellent question. I'm afraid that since it's coming in through a Q&A, I can't give you more specifics on that. So the person who asked that question, maybe if you want to reframe that question, we can certainly pose it back to Diane a little bit later in the call.
Yeah, I guess I'm not, like, I can kind of take a stab at this, but we weren't including, we were just focusing on the antipsychotic prescriptions here through the Ontario Drug Benefit prescription database.
Okay, thanks, Diana. So the person who asked that question, by all means, if that wasn't the answer to the question you had hoped, then by all means write in and ask a clarifying one, and we can put it to Diana later in the call.
Yep, that would be great. Thanks.
Great. So thanks very much to all three of you. Some very interesting findings, and we really appreciate all that excellent work. So we're going to move along to the discussion portion of our webinar today. I'll just quickly flip back past the two summary of findings that we have for both the question around insomnia, agitation, and delirium, and also around dementia. And certainly, as you would have heard from some of those discussions, lots of different kinds of information in this data and lots of different findings. So in some ways, having a high-level summary like this doesn't do justice to all the great work underneath. But that's part of what we want to discuss going forward is where do we take this, how do we share these findings. So without further ado, I'm going to invite our facilitator to join us here today. So Dr. Sasha Bhatia is the director of the Women's College Hospital Institute for Health System Solutions and Virtual Care, and a staff cardiologist at Women's College Hospital and University Health Network. He's the evaluation lead for Choosing Wisely Canada and the chair of the Choosing Wisely Committee for the Canadian Cardiovascular Society. So Sasha, we'd like you to welcome you to this webinar, and I'll turn it over to you.
Great. Thanks, guys. And thank you all for being on the call and on this webinar today. And thank you to the teams. I think it's been a pretty exciting, first of all, a lot of work to put these submissions together in such a short time frame and some pretty exciting data. As you all know, you can ask questions on the Q&A. And we can. I think we still have our teams on the line if there are other questions. So, one of the things, I guess, just a couple thoughts. First of all, I guess we have our poll, which is, do we think these submissions? This is for the group. Do we think these submissions increase your understanding of prescribing issues in older adults? So take a minute or two. I think the poll question, you should be able to answer them, and we'll come up with the results fairly shortly. One of the things that it strikes me, I guess, as we look at this, just some preliminary thoughts about the data is it seems like there's some pretty significant signal from all of these groups, no matter which type of data that they're pulling from, that there still is probably a higher degree of prescription of both antipsychotics and benzodiazepines in the older populations. And while this might be higher in long-term care and in institutional care, there still seems to be, to me, probably a significant amount in the community as well. And as a physician who sort of takes care of some of these patients, I think it fits with what I've been seeing clinically. And I guess what's interesting for us, as clinicians, and it'd be interesting to get people if they want to ask questions on the or comment on the board, is the question that we've known about this for a long time, and I'm curious to hear about why people think these prescription rates have stayed relatively high over a pretty long period of time. So it'd be very interesting, I think, maybe to get people's thoughts.
Sasha, we're just closing the poll right now, and the results should be up momentarily.
Great. Okay. there was a question on the board as well. We just got about what was the source of the antipsychotic data, and the answer was from the Ontario Drug Benefit Database. This is from the last presentation. And so that was sort of the answer to one of the questions. And now the poll results are just up, and what we see is, do these submissions increase your understanding of prescribing issues in older adults? And 64% of people said yes, that it does. 7% said no, and 29% said I don't know. And I just maybe, if the panelists are on the phone, wouldn't mind asking them, did they find the other panelists' submissions interesting, or did they, were there any surprises from what they saw from the other, submissions?
Do our raters want to answer Sasha's question first?
Yeah, I'll chime in on what Chris really pointed out very clearly in his presentation, and that group that did not have any signs of aggression or psychosis, who were still receiving antipsychotics. And to me, I think if we're going to make improvements in the appropriate prescribing of antipsychotics, I think it's in that group where we're going to make the biggest impact.
Okay. Yeah, it's Chris here. Another thing, I think, with all the presentations too, I think which all showed the various ways we can come about understanding this issue is that is actually reflected in the questions we received, in that we don't know why, right? And without these this kind of information that can be kind of, I found it rather shocking in all of the results. That we really need to start asking why and finding the appropriate methods to really pinpoint why this might be happening.
This is Simon from InfoWay, and to your question about some of the other submissions, Sasha, one of the things I found interesting was that we did have some submissions that came from primary care organizations looking at their own patient databases. And to me, that was an exciting finding to have people starting to troll through their own data and try and understand their own prescribing patterns. And so I definitely came up with the question of, okay, how can we encourage more of that kind of clinical analytics at the point of care on people's own patient populations?
Yeah, no, I think that makes a lot of sense, and I would follow up, that ask. People are asking the question why. We clearly, I think all three teams have identified that there's probably some significant improvement that could be done. So, one of the questions, I think that we have here in terms of the, what have we learned, and I think you can all see these comments. You can ask comments about, do these numbers seem correct? Is this data generalizable? And I think, it would be great to get other people on the webinar to submit anything that they, any of their comments. But it strikes me as, does anyone have a thought as to why these numbers seem to be as elevated as they are? Because they certainly seem higher than one would imagine. It certainly does seem to me like that the numbers seem at least comparable. When you look at the three submissions, the numbers seem similar across these three submissions. So I think to the first question, the numbers do seem to be correct. And I think, speaking as a clinician, although it's anecdotal, it certainly seems to be similar. Do you think this is generalizable? Do people, on the phone or on the webinar think that this data either is generalizable to other provinces, potentially as a general phenomenon, or do they think this might be, a bit more specific to the individual submissions?
So I'll start. the data that we use in our submission is essentially census-level data. And so we don't really start thinking about generalizability. We take this as this is the truth. And so because we had so many provinces represented in our analyses, I think that these rates will be true across all the provinces in Canada for the most part. There may be, small variation within certain regions, or depending on what the provider mix would be, or kind of what the setup would be in terms of regulations in long-term care. And I understand that CCC is kind of a care setting that's kind of unique to Ontario and a little bit of Manitoba. So things would be a little bit different in that situation. But I think overall this is very generalizable, and these rates certainly we show that while they are increasing and decreasing depending on what setting you look at, the change isn't that dramatic over time. So I would say these results are very generalizable.
I think one issue, or not issue, but an extension of that is that while the reporting and the numbers we're seeing are sort of representative, I think what would be more interesting is when we start to dig into the numbers a little further to see if the issue in itself is generalizable. In other words, is it the same factors that are contributing to or at least associated with this type of prescribing pattern that is consistent across provinces, or are there unique circumstances or unique sort of, case mixes of individuals within certain provinces that tend to be associated with receiving these kinds of medications compared to other provinces? So while the numbers do reflect sort of the status or the situation in at least some of these these larger databases, I do wonder how generalizable the issue in itself is, or whether it's province specific.
No, I agree with you, Chris. And I think what would be very, very interesting is if we looked at case mix and then also looked at region, and if there was large discrepancies there across the nation, well then that speaks not so much to patient need, but more to prescribing patterns, and that that gives us a great opportunity to intervene and work to reduce these rates if there is a big discrepancy between case mix and region, for example.
Yeah, for sure.
So those are great points, and I think it certainly seems like this has been a really excellent snapshot of sort of what's happening. But it sounds like more work probably needs to be done to delve into some province-specific data. Although ODPR did give us some sense of what's happening in Ontario, as well as perhaps some of the reasons as to why why these type of practice patterns are evolving. I just going to move to poll question number 2. So for those on the webinar, the question we would ask is, how would you like to get this data? It seems like people find it important and interesting. Would you like it to be, and you can see the ABCD. 1 is access source submissions. 2 is sort of blog, white paper, not peer-reviewed, but sort of, sort of real-time sort of data on a blog or white paper, conference presentation, or peer-reviewed publication. So I think you can answer that question by clicking one of the boxes. Certainly, there's pros and cons to getting each of the different sources. Obviously, peer-reviewed publication is great, both for the research team as well as for the literature and the community. However, it obviously takes a bit of time. Whereas perhaps the literature on a blog or a white paper might be faster to get to, but at the same time, you have to balance that with it may not be peer-reviewed. It might then not have the same degree of scrutiny in terms of methodology. So it would be good to get everyone's thoughts, sort of as to what would be the best way InfoWay and the research community could sort of share this data. And I think we're just going to do our poll answers now. I'd ask the teams are they thinking about publishing this data in a peer-reviewed way, or are they thinking about presenting it outside of what we've done here? Are there other ways that they're thinking about putting this data out into the public?
Yeah, so the Interact Canada sort of presentation, yeah, we're working on trying to explore the issue a little bit further for you know, a peer-reviewed publication, but we're also thinking of ways to present this in other kinds of forums wherever possible, whether it be media or conferences as well.
That's great. So the answers are up, and it looks like, you know, accessing source submissions is 6 out of 12, or 50%. Blog or white paper 3. Conference presentation 7 or 58%, and a peer-reviewed publication 75%. So the numbers didn't quite add up to 100 because I think some people added all that applied, but it certainly seemed like peer-reviewed publication was probably the most sought-after way that we should be able to share this data, although there were other fora that people were suggesting that we could access. And so now sort of also part of the discussion moving on, you know, is do you think we need regular review of this data to monitor progress? Should we be re-updating this on a regular basis? What are the implications of these findings? So what does this mean for health policymakers? I know some of them might be on the webinar. What does this mean for formularies and for clinical practice? And ultimately, how can you take this data for those, you know, decision makers that are here and incorporate it into your practice or into the work that you're doing? So, you know, I can imagine, you know, as you know, just speaking as, you know, someone from Choosing Wisely Canada, you know, it would be great to have a refresh of this data on a reasonably routine basis to see if there is change, you know, particularly as Choosing Wisely has made prescriptions of antipsychotics and benzodiazepines on multiple lists and has made it a priority, you know, to sort of have an impact on. It would be great to sort of see how that has made an impact on prescribing. So I would love to see it more regularly, but I'm not sure what other people's thoughts are. And I certainly think, you know, this is a big issue from implications perspective, because it does, not only are these medications expensive, they do cause harm, so particularly in this population. So it's a patient safety issue that, you know, potentially I think this research has definitely helped uncover. So we're seeing if there are, so people, there's a few minutes left if people want to enter in any other comments. There's one comment around a question for the group, which is, you know, should we be collecting this data in a more standardized way? You know, each used a slightly different methodology, but I guess a question would be, should we be trying to, you know, standardize the way that we're collecting and reporting this data so it's comparable across provinces? And I just throw that out there for the panelists.
Hi, this is Diana here. So I can you hear me?
Hear you.
Yeah, so that was one of the things that we were wondering about, because I guess the question was put out there and then every team kind of went on and made their own methods. And it would be nice, I guess, if people had the similar methods across provinces, but sometimes I think the data availability doesn't allow that. And so it's kind of neat to see the other methods that were out there and try and make those comparisons as to, oh, you use the RAY databases, how did that compare to using drug claims databases? So I think it kind of added a bigger picture to what we have right now, but I think it would be nice to have those methods across provinces. It's just sometimes hard to do.
That's great. Any other ones? Any other teams that want to comment on this?
Yeah, I mean, I guess getting to as close as real-time reporting as you can be quite difficult when we start to get at the sort of the pan-Canadian cross-provincial sort of analysis or reporting side of things. I think, you know, CIHI does what it can to try and achieve some of that with their data holdings. But I think it is sort of possible. It's just difficult with variations in the availability of consistent information, I guess. And so that's why, again, these kinds of initiatives are great for helping us to build ways in which we can get consistent data across Canada. But certainly sort of an annual reporting basis of this kind of thing should be feasible, I would think.
We have one question here, which is there was a consideration of has you guys considered adding some stratification to the extent of cognitive impairment or functional ability in any of the stuff you've done? So not just its presence, but the severity, I suppose. Has that been considered?
Yeah, that's where we're going with our manuscript. The research we're doing to sort of expand our report for the peer-reviewed publication is that's just it. We want to get at more of the granularity around the issue, around functioning, cognitive status, behaviors. You know, are there thresholds in which this kind of prescribing becomes more apparent, and perhaps that gives us insight into to more of the issue. So yeah, that's a great question.
Yeah, I think that's great, and I'm sure for clinicians, particularly understanding the extent of cognitive impairment, many of them or you know, behavioral issues, I think would be important when they're deciding whether or not to prescribe. So I think that's great that you guys are looking at that. So I think we're almost out of time. And so I think at this point, I'd like to thank the panelists and you know, the people providing the submissions for all their very thoughtful work on this, and for everyone who sort of come in. And I think I'm going to turn it back over to Simon to sort of close us off.
Actually, you're going to turn it over to Fraser, Sasha, and so
I'll turn it over to Fraser. Sorry about that.
No worries. I want to thank you for your time this afternoon. It was great for you to lead this discussion and to have some of your insight too. While I'm chatting, we're putting up our third poll, and so if there was another challenge, how would you like to participate? So if everyone would like to submit their answers for that. I'm going to continue on with the next steps. So we heard from each of you about how you intend to share your findings, but just as this challenge was an innovative way to actually discover some of these answers, I'd like you to consider some innovative ways to actually share your answers. So I think it's great that a lot of people want to go to the peer-reviewed route, but please also consider sharing your responses other ways, because this is how we can inform policymakers and decision makers out there about the health system by getting this data more out there. You'll notice that we have our next webinar scheduled for November 18th. It's on another of the challenge topics, and so I encourage you to join that. That is during Digital Health Week here at Canada Health InfoWay, so there will be a lot of things happening that week, and one of the good things that will be happening is this particular webinar, so please join us. Also, we are having a tweet chat on November 4th, and so we encourage you to participate in that as well. And if we could close the poll as I'm drawing this to a close, that'd be great. And so that tweet chat, you know, we'll be discussing some of these things, and we encourage your participation in that. So again, I'd like to thank Sasha and the team at Choosing Wisely Canada, and Sasha, your backup support, Kira, for making this webinar possible today. I'd like to thank all of the teams, the Inter-Raters, the Inter-I Canada, and Ontario Drug Policy Research Network for their talks today as well. The results of the challenge of our poll question are in, and it seems since most of you are participants, you see yourselves participating in some way as either a part of a team or a user of the data, so that's great. And so we will take that under consideration. And so I will leave you with one last thought is, stay tuned. We think this data challenge concept has been very exciting at InfoWay, and just keep a watch out because we may be back at you very shortly. So thank you to everyone and the team here at InfoWay for making this webinar possible, and have a dry afternoon if that's possible for those of you that are surrounded by all this rain today. Thank you very much for joining us.
Thanks again, everyone.
Thank you again for joining us. This concludes today's web conference. You may now disconnect.